When Professor Adra invited me and told me that the theme of this meeting was prevention, I suggested a topic that I believe it's very important and central to obstetrics and gynecology. It's the prevention of medical errors. Indeed, I'm going to tell a story that was my survival as chairman of our Department of Obstetrics and Gynecology at Cornell. I first became chairman at Cornell, about 15, 16 years ago. It was the time when Professor Adra first invited me to my first visit to Lebanon. It was 15, 16 years ago. And the malpractice insurance that I had to pay as chairman was $220,000 for each one of my doctors. A ridiculous number. That's not for the whole department, for each one of my doctors. And unless I did something aggressively, I'd no longer be standing before you as chairman. I want to relate to you our actual experience, what we did that was successful, with the hopes that this may translate to your experience. The first reality that we have to face, everyone makes mistakes. Each one of you in this room, myself included, makes mistakes. With increasing frequency with my children, I tell them I'm not infallible. Studies have been done in the United States with our Institute of Medicine, a very prestigious body, that have shown that hospital errors are one of the leading causes of deaths, greater than diabetes, influenza, and other major disease groups. It's been shown that 3 to 4% of hospitalized patients have preventable injuries, and about half of these could be avoided. Let me relate a personal experience. During the past year, my 92-year-old mother unfortunately suffered a hip fracture at home. I made a decision, and I know it was the right decision, not to bring her into the hospital to have the fracture corrected. I was certain it was going to kill her. And I know this was the right decision. She's comfortable at home. We know that hospitals are a dangerous place, especially for older people. What we have to realize that most of the problems are not individual errors. They're system errors. When you look around you at the people you work with, most are good people. Systems are the problem. There's much that we can learn from the airline industry. Some of you may be old enough to remember one of the great disasters in the Canary Islands, where almost 600 people died from a miscommunication, where 2 airlines collided on the ground just because they didn't communicate. Completely pointless death of 600 people. The airline industry knew they had to do something. Otherwise, myself, Professor Kuriak, Diego, the other professors here wouldn't come if it wasn't safe to travel on a plane. What they developed was team training. And we're going to talk about this and how it relates to us in obstetrics and gynecology. And they have proven that this is an effective tool to improve communication. Indeed, we know that it's much safer to get on a plane than it is to drive in a car. Human errors are inevitable, and we have to face this as a fact of life. What the challenge is, whether it's the airlines or for us in obstetrics and gynecology, are to look for ways to anticipate and avoid errors. Now, as I said, this is not just theory for me. This goes beyond the ethics discussion we had yesterday and we're going to talk about later. This is a real-world experience. And as I said, when I took over as chairman, as I pray in Lebanon, the American cancer of the professional liability crisis never comes to you, but it probably will. And it's essential that you get your house in order so that you can control this. And I want to give you a real-world experience that we were successful in doing this and had dramatic results in reducing what we paid out to the lawyers. This is a success story that we published. Let me present a typical case that happens in America. This was a patient that was admitted with ruptured membranes. Oxytocin was started. Cesarean delivery was done for bradycardia, decelerations. The baby has cerebral palsy. It's not clear that what the doctor did was any error at all. $13 million. Some of our cases go for much more than this. It's essential that we have systems in place that protect our doctors and protect our patients. An important theme I want to emphasize, concomitant with these safety efforts during the past decade, our cesarean section rate went down. Just because you increase patient safety doesn't mean you increase the cesarean section rate. And I'm very proud of this fact. We're going to have more to say about this. We made the decision to make significant changes to our culture. To use an overused word, the culture in our departments have to change. Now, there are many interventions that we did. In the short time we have, I want to respect the program. We don't have time to go over everything. I want to highlight the most important changes that we made. I think you may be familiar what this picture represents, the Tower of Babel. When God wanted to punish mankind, he made mankind speak in many languages. Some of my friends, like Azam Kuryak, are gifted. They can speak many, many languages. I'm limited. I speak only English. Here in Lebanon, you're fortunate. You're a multilingual society. The point I'm trying to make, we have to communicate. I was brought up in a Christian tradition and was taught there's 7 deadly sins. You may be familiar with these: lust, gluttony, greed, sloth, wrath, envy, and pride. When you think about it, in obstetrics and gynecology, these are not the big sins. I suggest the biggest sin is miscommunication. And when you think about it, in your personal lives, those of you that are married, think about the fights that you have with your husbands or your wives. Are they over real issues or because of miscommunication? Something that wasn't said or something that was misunderstood. Those of you who have children, think of the fights you have with your children. Think about the fights you have with your friends. How many of these are due to real issues or miscommunication? Now, whatever happens in our personal life, this is translated to the work setting. And what happens when the attending miscommunicates with the doctor in training, with the nurse, with the anesthesiologist, with the pediatrician, and it's magnified, patient care suffers, and lawsuits result. I mandated that all of our doctors take a course that we teach called TEEP training. It sounds so basic, but the simple course, I believe, was transformative in patient safety and in risk reduction. And very simply, it's no longer enough for an attending to grumble something. The nurse has to check back to make sure that the nurse heard what the attending said. Someone can challenge what a doctor says. Handoffs are significant. It sounds so simple, but it mandates effective communication. I can tell you, we had a maternal death, it was almost 15 years ago, because a patient exsanguinated. There was miscommunication from our labor delivery to the blood bank, and the blood products didn't get up there fast enough in a case of postpartum hemorrhage. And hence, we did a root cause analysis, and this problem was alleviated. Miscommunication has many, many forms. drills are so important. Who is there in the middle of the night, whether it's in New York, Beirut, Lebanon, or the various locales that you come from? It's not going to be the most experienced doctors. It's going to be the most junior doctors. And they need to know what to do when emergencies happen, whether it's shoulder dystocia, postpartum hemorrhage, a cardiac arrest, or a stat cesarean delivery. I mandated drills so that everyone knows what to do if these happen. And in our litigious environment, everyone knows what to document on the chart if there's a shoulder dystocia. And knock on wood, in these past few years, we've not had we have shoulder dystocia, we haven't had Erb's palsy, because shoulder dystocia is managed effectively. If you're going to deliver babies, you'll have shoulder dystocia, but everyone knows what to do and what to document in the medical record. Later today, we're going to talk about home birth. I argue that when you need to do a cesarean, you need to do a cesarean. We do drills to fight for seconds so that when you do a cesarean and call for a cesarean, it can be done immediately. Amos Grunbaum, our chief of obstetrics, runs these drills, and he does these beautifully so that everyone knows what to do in emergency, the most junior doctors, the nurse, the whole healthcare team. I have to tell you, at first some of my doctors objected to this and said, Frank, what is this all about? Why do I need to take such a basic training? Now no one objects, because this simple intervention has yielded dramatic results. This was our nursing station, similar to your nursing station, and I'm sure you have a labor and delivery board. We introduced an electronic board that's simultaneously updated, and again, it avoids miscommunication. Everyone knows what's going on so that there's not miscommunication. Color coding of labels. I confess a mistake I made years ago when I was a doctor in training. There was a patient who had fetal distress. And what do? You open up the intravenous to give more fluid. I made a mistake. At the time, I was up all night the previous night. It was a Sunday. I came in the Saturday morning. I was up all Saturday night, and I opened up the intravenous with oxytocin. So sure enough, I caused more fetal distress. We had to do an emergency cesarean delivery. Fortunately, the baby was fine, but an unnecessary cesarean was done. I'm delighted my superiors at the time didn't make a judgment that I was an incompetent doctor. It was a bad system. What we've done is color code the bottles so that they're not mixed up, magnesium sulfate and oxytocin. Good people make mistakes. The simpler we make things, the less we avoid mistakes. Chain of command. So simple. The days of a doctor, I believe a doctor in attending is captain of the ship, but he's not an absolute authority. I carry my cell phone with me wherever I am, in Beirut, anywhere in the world. Why is this? Not to manage my patients, no. My doctors can do that much better than I can. But if there's a problem, if one of my doctors isn't acting appropriately, there's a chain of command. I want to know about it. There was a case a few months ago where one of the physician's assistants called me because the doctor was acting inappropriately. I congratulated that physician assistant. I much rather know about something here in Beirut in the middle of the night than to come back home and have a brain-damaged baby. There needs to be a chain of command in every obstetric service to avoid problems. Medication error. The Institute of Medicine has shown that medication errors are disastrous, and the biggest problem is oxytocin. I come from Cornell. the institution where 50 years ago, Duvigneau won the Nobel Prize for the discovery of oxytocin. We can have debates whether this is a net advantage or a net disadvantage to modern obstetrics. My friend Phil Steer in London has said we should get away with oxytocin, just forbid it, because it does more harm than good. I disagree. I'm not sure if he truly means that, but I believe there needs to be a standardized oxytocin protocol on every labor and delivery service. If there are too many protocols, it's a setup for disaster. People get tired, errors are going to be made. My own American college, which I'm a loyal member to, believes that there can be several protocols. This is a setup for disaster, in my opinion. In my opinion, every one of your departments should have one protocol so that there's no confusion and everyone follows the protocol. A controversial intervention that we implemented was the standardized protocol. And I decided, Amma suggested, and I agreed, that our attendings could not touch the rate of infusion of oxytocin. It had to go by protocol. At first, some of my senior doctors objected and say, Frank, we're going to increase the cesarean section rate because I can't increase the oxytocin fast enough. It was the exact opposite. What happened was there was a decrease in the cesarean section rate because there was less fetal distress, because less hyperstimulation. We found that it was better not to use misoprostol for induction. You still can use it for abortuses, but not for induction with live fetuses. This is a controversy. Some units use it, some don't. We made a decision as a group it was safer not to use it. My main clinical interest is ultrasound. There are many ways to be sued in ultrasound. I mentioned yesterday in the Indonal course, document, document, document. You have to document your images. And I just want to mention miscommunication. I've been sued one time in my career in ultrasound, and it was a communication issue. I told the referring doctor there was an anomaly to have the pediatrician evaluate after birth. He didn't do it. There was a lawsuit. Fortunately, the doctor was honest and said, of course, Dr. Chervenak told me to do it, and I was dropped by the lawsuit. I didn't document it. He was an honest doctor. So it's essential to document everything. What I'm suggesting is that these interventions can and do protect our patients and protect us from medical legal problems. For centuries, medicine has been based on individual achievements, and this is all good, but teamwork is essential today, more than ever, to achieve these results. Albert Einstein said it well, doing the same thing over and over and expecting different results is insanity. I can't emphasize to you enough, and one of the important take-home messages, miscommunication is the deadliest sin. Reflect on your personal lives, and I think you'll agree with me, in your professional lives, miscommunication is a killer. In our professional societies, the disputes that arise more often than not are miscommunication issues, not issues of substance. Charles Darwin has said it so well. It's not the strongest that survive, nor the most intelligent, but the one most responsive to change. This is a country with a wonderful, wonderful history. Our country is not so old. I'm proud to come from the second oldest hospital in America. In fact, we're older than the United States. The original title was the New York Hospital and Lunatic Asylum. We try to have a culture of sanity in obstetrics.
1 minute, please.
One more minute, and then I'll end. One more minute. And just to show the cultural difference. Our results were so good that the malpractice lawyers actually tried to introduce into the New York State legislature, saying that if Cornell could do it so well, we don't need to have tort reform in the United States. It was the only time I ever wrote to the New York Times and said, this is ridiculous. Doctors write for doctors. Lawyers, they're big. We don't have time to go into the legal issues in the United States, but I'll close again. We can do much for prevention. Let me stop at this point. Thank you so much. Thank you.
Thank you, Dr. Sir.